mature white cataracts. So the major challenges in phaco emulsification in mature white cataracts are absence of red reflex and raised intralenticular pressure, which causes difficulty in doing the rhexis, and there is lack of epinuclear and cortical cushion during phaco emulsification. So this is a white intumescent cataract. You can see here the swollen cortical fibers here, and here you can see clear areas of liquid cortex, and this lens is intumescent and the anterior capsule is convex. So the first thing is to counter pressure the high intralenticular pressure by injecting viscoelastic into the anterior chamber and to make the anterior capsule flattened so that there is no rhexis extension. So the second thing is to improve visibility, you have to use capsule staining devices like agents like Trypan Blue. Here Trypan Blue staining is done under air bubble. So this air bubble ensures uniform staining of the capsule and prevents staining of the endothelium. Now after clear cornea incision, the nick is made in the capsule. You can see the leaky cortex, and then you have to inject OVD in the peripheral part of the anterior chamber, not in the center, so that there is no chance of rhexis extension, and a primary capsulorhexis is made. And don't inject too much of fluid into the bag for cortico-capsular hydrodissection, because it will increase the bag pressure. So aspirate the loose fluffy cortex, and now the intralenticular pressure has come down and there is no chance of rhexis extension. Now a tangential cut is made on the primary rhexis and the secondary rhexis is done. Now the phaco emulsification is not much different from routine, but there won't be much of a cortical or epinuclear cushion. So you should be very careful not to damage the posterior capsule, and then a single piece intraocular lens is implanted inside the bag. Now in this cataract, you can see the swollen cortical fibers and the lens is highly intumescent, but you don't see any fluid clefts here. So when you are doing a capsulorhexis here, you don't see any leaky cortical matter coming out, but you can see the swollen cortical fibers bulging out of the rhexis. So these capsules have got high chance of rhexis extension, so you should be very careful. You should nicely flatten the anterior capsule by injecting OVD. Now the loose fluffy cortex is being washed out, but it doesn't come out very easily as in the previous case because there is no liquefaction there. Now once that is done, then the danger of extension is less and the secondary rhexis is being performed. And here in this case, actually the nucleus is very small and it is soft. So there is increased mobility of the nucleus. So I am doing a direct chop so that it holds the nucleus, and the phaco emulsification is being done. In these cases, the bag will be very loose. So during cortical aspiration, there is a chance that the probe will catch the posterior capsule. So that also should be taken care of. Now, this is the third type of mature cataract. In this case, it's a mature cataract, but the intralenticular pressure is not high. Why? Because the anterior capsule is not bulging. It's a normal, mature, well-dilated cataract. So here you can attempt the rhexis in the normal manner. See, here I am doing the rhexis without any aspiration or filling the anterior chamber with OVD. Now if you want, see, initially when the mature cataract will tend to do a small rhexis initially, and if you want, you can do a spiral rhexis and then enlarge the rhexis according to the situation. But in these cases, there is no chance of rhexis extension, so you can do a phaco safely. Now coming to the fourth scenario, here this mature cataract is, the cataract is mature and this intumescence, but there is a uniform ground glass appearance under the capsule. So here the entire cortex has liquefied, and the moment I nick the capsule, the fluid starts coming out. So all these things are aspirated, and the one thing with this is that once you aspirate this cortex, then there is absolutely no risk of rhexis extension. So only thing is, when you are pulling the capsule, you will have a leathery feeling because the cataract has been mature for a long time. So there is a leathery feeling, but there is no risk of extension. But the thing is, doing phaco will be a little challenging because the nucleus will be a small button at the end of this. So it will be highly mobile. So you will have to hold the nucleus with a second instrument, and then you will have to do phaco. Here actually I have taken out the nucleus through an SICS, but if you are planning to do phaco, you you have to inject visco in the back, and then you have to stabilize the nucleus with a second instrument so that it doesn't move, and then you will have to do a direct chop. Or you have to prolapse into the anterior chamber and then do anterior chamber supracapsular phacoemulsification. But in these cases, the capsule is going to be very floppy, and while doing cortex expiration, you should be very careful. And in such situation, you can do an IOL scaffold also before removing the final piece or before removing the final nuclear piece. So this is a video which shows a rhexis extension. As you can see here, the lens is highly intumescent and the anterior capsule is very convex. And even though I injected OVD to flatten the capsule, there was rhexis extension. The moment I hit the capsule, the liquid cortex came out, that was aspirated, and the rhexis was done, primary rhexis was done, and while removing the swollen cortex, actually some of the fibers were not coming out. It was very sticky. So when actually you can see the peripheral area, still there is convex bulging. So when I was coming here, see suddenly it went to the periphery. So while trying to retrieve, it was not coming. So what I did is made a second cut from the opposite area and tried to complete the rhexis. And here one good thing was the nucleus was soft. So I just prolapsed it into the anterior chamber and did a supracapsular phacoemulsification. So here one thing is you should use low phaco parameters, that is low bottle height and flow rate, so that you don't further cause damage to the torn edge and make it a wraparound tear. And another thing is, before pulling out the phaco probe, you have to inject OVD to the side port so that the posterior capsule doesn't come up and the tear doesn't extend. See, one thing what I want you to notice is that, see, here if you are seeing the capsule flap is fluttering, so it is not inward, it is outward. So this means that it has not extended beyond the equator and it is just staying at the equator. And the cortex and the area of the rhexis is removed last very carefully, and then a 3-piece lens is placed inside the back. Actually, I wanted to place it in the sulcus, and the first haptic has gone to sulcus. While dialing the second haptic, the whole lens went into the back, but it remained stable because there was no extension to the posterior capsule. And that capsule flutter sign is a very important sign that was described by Dr. Rohit Om Prakash. If it is fluttering and everted, you can place the lens inside the back, but if it is inverted, then you should not place it inside the back because it has gone beyond the equator. And now in certain situations, actually you can aspirate it with needle also, this cortex. So here a 27 gauge needle is used to aspirate the liquid cortex. As you can see, the liquid cortex is being aspirated. But only thing is, when you are doing the initial puncture, there is a chance of this developing argentine flag sign, so you should be very careful. Another thing is, instead of taking it, this way of doing it, instead of folding the capsule and taking it, you can just tear it so that it doesn't go to the periphery. The pull will be towards the center. So that is another way of doing the rhexis. Now finally coming to the practical tips. So few things is, you should always stain the anterior capsule. And next you should counteract the increased back pressure by injecting OVD and keep the anterior capsule flat. And a microrhexis forceps. Many of the times you saw me using microrhexis forceps, so it gives a better control over the rhexis than cystostome. And all the rhexis manipulations, that is whether it is primary rhexis or doing second rhexis, should be done through the side port so that the gel doesn't come out to the main tunnel. And the hydrodissection should be very gentle, and phacoemulsification should be careful because there is lack of epinuclear support. And you should be careful about the flaccid posterior capsule during cortex removal. Thank you.
So that was an excellent presentation by Sandhya. Just two simple questions. Will you do any anti-IOP lowering agents, and what is the choice of anesthesia? Whether you give a block or you give a topical?